Hello, I'm Dr. Wendy Wright, an adult and family nurse practitioner. Thanks so much for joining me. Today, I'm going to talk about inhaled corticosteroid, or ICS exposure, in asthma treatment. Let's start with why it's important to consider ICS in your patient's asthma rescue treatment. For decades, patients have relied on SABA-only rescue for relief of their asthma symptoms. But SABA alone doesn't address inflammation, leaving patients at risk of exacerbations. That's because inflammation and symptoms vary over time and intensity. And while maintenance therapy helps address baseline inflammation, it may not always be enough to address variability in inflammation, even when patients are adherent to their maintenance therapy. This is where ICS-containing rescue comes into play. Global asthma experts from GINA, short for Global Initiative for Asthma, support an anti-inflammatory rescue approach for all adult patients with asthma. These experts have recommended against SABA-only treatment of asthma in adults since 2019. When choosing an anti-inflammatory rescue approach for your patients with asthma, a common question might be, how much ICS exposure would patients get if using both an ICS-containing maintenance and a rescue that includes an ICS? This question was examined in an observational, retrospective U.S. administrative claims study that included data from more than 500,000 patients who were at least 12 years of age with asthma across all severities. A key objective of this study was to estimate the daily ICS exposure that would occur if patients were to use an ICS every time they use their SABA rescue for symptoms. The total estimated ICS exposure was calculated by combining observed and projected ICS exposure. Observed exposure was based on post-index prescription claims, using proportion of days covered and assuming full use of the prescription fills, and was expressed as micrograms per day of fluticasone propionate equivalents. Projected exposure reflected additional ICS exposure if 50 micrograms were delivered with each SABA rescue inhalation, based on mean SABA fills in the post-index year. The mean total estimated ICS exposure per day was calculated by adding the observed ICS exposure resulting from maintenance therapy to the projected ICS exposure that would result if every SABA rescue inhalation was combined with an ICS. The mean total estimated ICS exposure per day is highlighted in purple. This study showed that the estimated total ICS exposure from the use of an ICS with a SABA as rescue therapy on top of an ICS-based maintenance therapy did not exceed the daily maximum FDA-approved ICS dosing at each step of therapy, shown in the orange and red gradients. Now we will shift to evidence from randomized clinical trials to discuss ICS-related safety of AIRSUPRA and albuterol. AIRSUPRA is the first and only FDA-approved anti-inflammatory rescue that treats bronchoconstriction and helps prevent exacerbations. AIRSUPRA is a combination of albuterol, a beta-2 adrenergic agonist, and budesonide, a corticosteroid, indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. Important safety information. Contraindications include hypersensitivity to albuterol, budesonide, or to any of the excipients. Deterioration of asthma. Asthma may deteriorate acutely over a period of hours or chronically over several days or longer. If the patient continues to experience symptoms after using AIRSUPRA or requires more doses of AIRSUPRA than usual, it may be a marker of destabilization of asthma and requires evaluation of the patient and their treatment regimen. Please see additional important safety information for AIRSUPRA at the end of this video. The safety and efficacy of AIRSUPRA were evaluated in a Phase 3b, randomized, double-blind, patient-centric, event-driven exacerbation trial with a minimum duration of at least 12 weeks in 2,421 patients who were at least 12 years of age with intermittent to mild persistent asthma. 26% of patients were taking SABA plus low-dose ICS maintenance therapy or leukotriene receptor antagonists, LTRAs, as their pretrial asthma therapy. In this trial, common adverse reactions reported in greater than or equal to 1% of patients who used AIRSUPRA versus albuterol were headache and cough. Here, we see the ICS-associated adverse events in patients with intermittent to mild persistent asthma, where ICS-associated adverse events occurred in less than 2% of the participants in each group. AIRSUPRA was also evaluated in a Phase 3 randomized, double-blind, multi-center, variable length exacerbation trial with a minimum duration of 24 weeks in 3,040 symptomatic patients who were at least 12 years of age with moderate to severe asthma. All patients in this trial were receiving daily ICS-containing maintenance therapy. Patients in this trial reported using their maintenance therapy on average more than 75% of the days. In this trial, adverse events were similar for both treatment arms. The most common adverse events reported in greater than or equal to 1% of patients who used AIRSUPRA were headache, oral candidiasis, and cough. The frequency of local ICS-associated adverse events in patients with moderate to severe asthma were similar across treatment arms. Based on what we've covered, let's recap the key takeaways. We talked about the variability in inflammation in asthma and why maintenance therapy may not always be enough to address it. We also examined estimated ICS exposure from both ICS-containing maintenance and rescue if an ICS was included based on claims data. Finally, we discussed ICS-associated adverse events in AIRSUPRA clinical trials. Scan this code to learn more about the first and only FDA-approved anti-inflammatory asthma rescue at AIRSUPRAHCP.com.
AIRSUPRA Important Safety Information. AIRSUPRA is contraindicated in patients with hypersensitivity to albuterol, budesonide, or any excipients. Asthma may deteriorate acutely or chronically. Continued symptoms after AIRSUPRA or increasing doses of AIRSUPRA may be a marker of asthma destabilization and require evaluation of the patient and their treatment regimen. AIRSUPRA can produce paradoxical bronchospasm, which may be life-threatening. Discontinue AIRSUPRA immediately if paradoxical bronchospasm occurs. Paradoxical bronchospasm frequently occurs with the first use of a new canister of an inhaled formulation. Drugs containing beta-2 adrenergic agonists can produce clinically significant cardiovascular effects in some patients. If these occur, consider discontinuation of AIRSUPRA. Beta agonists have also been reported to produce ECG changes such as T-wave flattening, QT interval prolongation, and ST segment depression. Therefore, as with all sympathomimetic amines, AIRSUPRA should be used with caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Do not exceed recommended dose. Clinically significant cardiovascular effects and fatalities have been reported with excessive use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, as demonstrated by cases of anaphylaxis, angioedema, bronchospasm, oropharyngeal edema, rash, and urticaria. Discontinue AIRSUPRA if these occur. Like all therapies containing sympathomimetic amines, AIRSUPRA should be used with caution in patients with convulsive disorders, hyperthyroidism, or diabetes mellitus, and those unusually responsive to sympathomimetic amines. Beta-adrenergic agonists may produce significant hypokalemia in some patients. Decreased serum potassium is usually transient. Due to possible immunosuppression from the use of ICS, worsening of infections can occur. A more serious or fatal course of chickenpox or measles can occur in susceptible patients. Oropharyngeal candidiasis has occurred in patients treated with ICS agents. Monitor patients periodically. Advise patients to rinse their mouth with water without swallowing after inhalation. Hypercorticism and adrenal suppression may occur with very high doses in susceptible patients. If these occur, consider appropriate therapy. Decreases in bone mineral density have been observed with long-term administration of ICS. Regularly assess patients at high risk for decreased bone mineral density. Glaucoma and cataracts have been reported following long-term administration of ICS, including budesonide. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity in pediatric patients. The safety and effectiveness of AIRSUPRA have not been established in pediatric patients, and AIRSUPRA is not indicated for use in this population. The most common adverse reactions are headache, oral candidiasis, cough, and dysphonia. AIRSUPRA should be administered with caution to patients being treated with strong cytochrome P450-3A4 inhibitors, which may cause systemic corticosteroid effects, short-acting bronchodilators. Concomitant use of additional beta-agonists with AIRSUPRA should be used judiciously to prevent beta-agonist overdose. Beta blockers, which may block pulmonary effects of beta-agonists and produce severe bronchospasm. Diuretics, or non-potassium-sparing diuretics, which may potentiate hypokalemia or ECG changes. Consider monitoring potassium levels. Digoxin, which may decrease serum digoxin levels. Consider monitoring digoxin levels. MAOIs or tricyclic antidepressants. Use AIRSUPRA with extreme caution, as these may potentiate the effect of albuterol on the cardiovascular system. Use AIRSUPRA with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. These are not all of the side effects for AIRSUPRA. Visit www.airsuprahcp.com for additional information, including full prescribing information and patient information.